Hi, everyone. Thank you for joining us today on this Friday. Today, we're going to be talking about understanding opioid addiction in treatment. We have our two members from our clinical team discussing this topic today. We have our clinical director, Rich McDonald. Before we get started, just so you guys know, there's a few different handouts in the handout section of your control panel. You can download them straight from your control panel and take them with you. They just discuss our program, some of our different specialties in our admissions process. And then one more thing, you can ask any questions at any time during the webinar and we'll make sure they get answered. The way you ask the question is by typing it into the control panel. That's all I have, so I'll turn it over to Rich and Kevin.
Good morning, everybody. Thanks for joining us. As Kayla introduced us, my name's Rich McDonald. I am the clinical director at Wasatch Crest. I have been here since the beginning, about 6.5 years, and I was excited to have Kevin join us. I have, for most of my career, worked in addiction treatment, and I am grateful that I get to do that. I love this population. I love to work with our clients or patients and see, when the light kind of comes on and the incredible, beautiful lives they can build in sobriety. It's different than a lot of the other areas, I think. When you see somebody get it, it's such a dramatic shift, and I love doing it, so I'm grateful to be here doing what I do.
Great. Hi, my name is Kevin. I'm really excited to be here as well. Have sort of a long history in mental health treatment. For a very long time, worked with community mental health. Worked with the SPMI client population quite a bit, and also in addictions and recovery. I have taught DBT and been involved with dialectical behavior therapy for many years, and continue to love that kind of model and how it integrates into helping those that are struggling with addiction. But I've worked a lot with personality disorders and individuals that struggle with that as well. I've also been a state of Utah licensed crisis counselor, and have been a designated examiner for the state of Utah. So I'm super happy to be here at Wasatch Crest. We're working just with a great team, probably one of the newer members here, but I'm really excited. Nothing like the population of individuals that struggle with addictions, as far as just great bunch of people, and just love what we're doing. So happy to be here. Thank you.
Awesome. Thanks, Kevin.
Yep.
Okay, so Kayla, do you want to the next slide? Uh-oh, did we lose her? Oh.
The pandemic and opioid addiction, Rich.
What's that?
I changed to the side.
Oh, let me see here. It's not looking. Okay, I guess we're not seeing it on our end, sorry. The pandemic and opioid addiction. So I will just, everybody else can see it. The one that I've got, Kayla, is still the main slide. So we'll just go with it. So as everybody is very aware, the pandemic has brought some challenges to mental health and addiction and substance abuse. I think one of the things that we've seen initially with some of the new data coming out from the past year is that opioid addiction or opioid overdose death has gone up in 40 of the 50 states as far as the data that we have right now, which is frightening. We've made some progress, I believe, from the naloxone and the ability to buy, the overdose reversal drugs over the counter. In a lot of states, I think made an impact, and overdose death went down for one of the first times in many years in 2019, and the pandemic hit and we saw that that trend change. So that's pretty dramatic. Even over and above that, just the inability for clients to connect and attend live meetings, and for the recovery community to go virtual, I think has required an adjustment as well. And I fortunately don't know that it's been quite as effective. Even pre-pandemic, I know Kevin's got some statistics that are kind of mind-boggling, but
well, it's quite amazing, Rich, the staggering numbers that are occurring in our world and in the United States, of course. So there's like an estimate of 26 to 36 million people actually worldwide that abuse natural opiates and the synthetic opiates. So Americans, they're said to consume about 80% of the world's supply of opium-derived painkillers, with more than about 2 million Americans addicted to prescription opioid painkillers. So things like oxycodone, hydrocodone, and then there's another about 460,000 addicted to opioids like heroin and fentanyl. So we've seen a lot of problems and a lot of deaths, a lot of destruction. We see that all the time in what we do, and it certainly is a pandemic, and we're starting to kind of see that. I agree that things are getting much better here in our state. In Utah, doctors are becoming a little more mindful of that. They call that iatrogenic addiction, where it's physician induced. That has happened or contributed to a great deal to the pandemic. It's easy to get the pain pills, and they're starting to be much tighter with that. So that makes me hopeful.
Absolutely. And I think another thing to mention is, we're going to talk a little bit about the different approaches to treatment, medication assisted treatment versus abstinence treatment, and kind of what that looks like. But there was some news yesterday. For those of you that aren't aware, right now, the way maintenance program like Suboxone is a very common daily dose medication for the treatment of opioid addiction. Initially, when Suboxone was approved by the FDA to be used to treat opioid addiction, they required doctors to get a special license from the DEA to be able to prescribe the maintenance doses of Suboxone. And with the new administration coming on board, they were working to change the way that worked and allow all physicians to prescribe. And even in these first few days of the new presidential administration, they're working to get that pushed through. And it was in the news yesterday that they're pausing the plan to allow all prescribers to be able to prescribe it, so that they can kind of step back and do it the right way. Ultimately, I think it's pretty remarkable. 10 years ago, I don't know that we saw a lot about addiction, and the epidemic of addiction that was still going on. But the fact that it's getting news early on in the administration, I think, is a good sign. I think they're looking at it and really trying to see the best way to proceed. And we know that there's a lot of people out there that need help. We can do the next slide. Thank you. So risk factors and signs for opioid addiction. This one's interesting. I remember one of the things that I've seen happen just anecdotally with clients that are struggling and working with families. One of the things that the opioid addiction definitely brings is the withdrawal symptoms when somebody's not taking them. So that's kind of an easy one. When somebody's a daily opioid user and they don't get their daily substance or chemical, they go into withdrawals that look like a severe fever sometimes. Sometimes it's more mild depending on their level of daily intake. But one of the other things that I have seen and had people ask about is just the doctor shopping. There are so many different things that go into keeping an addiction alive, and so for families, I always talk, really looking for changes in mood on a daily basis, volatility of mood, increased drowsiness or nodding off or napping during the day, and then really the thing that I've seen especially is that euphoria, like suddenly somebody's really happy, talkative, and then 10 minutes later or 20 minutes later, they've kind of slowed down and they seem volatile and grumpy, and also changes in behavior or habits. So somebody might previously been really committed to something and passionate about something, and then suddenly they seem to not really care anymore. They kind of lose that excitement for things that they loved at one point.
Well, of course, with those individuals that have loved ones that are taking pain medications, you know, you often, it's not always monitored, but there's the same addictive behavior that happens in other places where they're hiding it, they're secretive. They may run out of their medications at a calling in prescriptions. I feel like the pharmacies are getting much better at that they won't allow that. Doctors that are aware of that will make sure it doesn't happen. The Doppel websites that help and control that are doing much better with that. But then you'll begin to see those intense withdrawal symptoms that may happen when they stop. You mentioned this earlier, Rich, just sort of the increased pain, flu-like symptoms, the headaches, vomiting, diarrhea, anxiety, and all that, the rebound anxiety that you see. So yeah, there's lots of signs, lots to be aware of for those that have loved ones that, you know, they don't always fit the stereotypical profile that we might see in an addict, and they certainly get lost or passed by often because people have pain. They have
Yeah,
chronic
absolutely.
pain.
And I've really, one of the things that we spend some time on with clients as well is oftentimes, and I do believe physicians have gotten more savvy and understanding opioid addiction, but initially there were many cases of people with like chronic back pain getting prescribed opioids. And what we've learned over time is there's hypoalgesia, which actually amplifies pain. So somebody that's taking opioids for lower back pain long term, ultimately it's making the pain worse. And I've seen it many times. Somebody comes in, I need it because of this back pain. I've got chronic pain, I don't have a choice. And if we can get them to try it for a minute and taper off of the medication, they feel terrible for about 10 days, but almost all of the time when we ask them to rate their pain, when they come in, they're like, it's on a scale of 1 to 10, what's your pain? And they're saying it's 12. You know, 10, 12, 14 days later, you ask them and they're like, you know, it's probably about a 4. And it really does, you know, that education piece and helping people understand how to manage pain without medication is helpful. And, you know, I've just seen it time and time again where we convince ourselves that we need something because it makes us, you know, feel better. And if we can get people to give it a try, they ultimately can have a far more productive and thriving life.
Yeah, I agree at the level of the synapse. There's a lot of change that occurs, as you said, Rich, and individuals do have a subjective experience of their pain as a very different place, and the body's own natural pain mechanisms begin to shut down more because it doesn't require, because the synthetic is present. So that's hard to get someone to that point, though, because of the psychological dependence or the generalization that goes into the rest of their life to cure every problem. Is it about the pain? No, it no longer becomes about the pain any longer. It becomes about the avoidance of withdrawal. And so some of the psychological factors that come in. So there's lots of great treatments, you know, when we look at treatment and how we treat that, we look at some different avenues.
Absolutely. Well, let's do the next slide. Okay, opioid detox and treatment approaches. So last week we had our nurse Susie Ware on, and we talked a little bit about the medical side of treatment. Now, opioid detox is one of those things where initially, you know, when I first started working in the field, it was very common for people to go cold turkey. We might give them some, you know, mild comfort medication to help them get through it. But kind of as we have gotten a little more sophisticated with that, a lot of times they'll do a 7 to 10 day Suboxone taper and get them off of the opioid if abstinence is the goal. And that's where kind of the tricky piece comes in, right? So opioid detox in and of itself isn't dangerous. We are capable of detoxing somebody, like social detox, which we're licensed for. We are capable of helping somebody through the opioid detox if abstinence is their goal, without being in a hospital or medical setting. Once they've been cleared and they've gotten a history and physical and the doctor feels like there's nothing else going on that could put them at risk. And it's really, that's a time where, we're trying to help the client figure out what's the best fit for them, right? Does abstinence, their recovery, is that the goal, or is maintenance going to be a better fit for them? And it really is kind of a case-by-case basis. I think that more and more we've seen a lot of clients that come to us and, they get here and we begin speaking with them and they start, hey, this is my 12th treatment or my 5th treatment, or my, oftentimes most of the time I would say, we're not their first treatment experience.
Yeah.
And they've made several attempts at abstinence. Maybe we need to have a serious discussion about maintenance and what that might look like for them. It's still one of the areas of controversy, I think. My initial thoughts around it have changed slightly, become more open to the idea of maintenance, and I know that it does save lives. And I think that we owe it to our clients to be open to all different approaches to treatment. One of the things that I've seen time and time again, somebody comes in and they automatically, I want to stay on a maintenance dose. And, I've tried abstinence before, I don't want to do it. And really kind of revisiting it throughout their treatment. Is that the best approach? And oftentimes they will come to us and say, you know what, I don't want to take this every day of my life. I'd like to taper off. And if we can help them do that, we're super supportive. And I think it's it's ultimately a good thing for a lot of the clients to have an abstinence-based recovery. I don't know, what are your thoughts?
No, I agree. I agree with that. I've been the same mindset that has questioned. I'm probably an abstinence guy. I think that would be best if people can do that. But in a harm reduction model, we certainly have the opportunity to probably save lives and have people that aren't quite to that stage of change in their lives. And my goal would be to get them to be there, but I'm still open to that. Maybe some might have to be on it. But if we can get them to the point where they can buy into getting to that point, that may take some time. Sometimes it's hard to come off of these drugs as well, the maintenance drugs. That can be a real difficult challenge. But for many, they're able to go to work, have a family, and still not have those parts of their lives broken up. So I think it's really important. It has its place. And we're still trying to figure out where that is, but it certainly has its place. And as far as treatment, different kinds of treatment, we know that, residential treatment programs, sometimes a medical detox going into a residential treatment program of 30 to 90 days, we see relapse rates for opioid addiction no higher than, or they tend to, the rates of the opioid relapse can tend to be a little bit higher, 40 to 60% than with other addictions. But we're seeing in recent studies that opioid-dependent individuals who stay in residential treatment for at least 6 weeks, followed by an outpatient, really great program, aftercare, of the highest recovery rates and the lowest relapse rates. I think that though there are lots of alternative treatments beyond residential and aftercare, of course, and I don't know that they've always gotten the most attention. There's things such as mindfulness meditation. I think it was John Kabat-Zinn that did some research years ago about that. And he brought him into their clinic, and it was as effective, if not more so, I think, than in regulating pain, learning to be very mindful and meditate.
Absolutely. And we were, talking about some of the goals, and oftentimes just like from our own experience, we've seen, there's such significant trauma in the population that we treat, especially for opioid addiction. So that trauma piece is huge. And really looking at their experiences, and especially with opioid addiction, I think that we've seen higher rates of trauma in people that come to us presenting for opioid treatment, and really like helping them work through that requires a lot more time than 30 days in residential. And I think that's a piece that people have been doing a much better job of. Ideally, we would get somebody here for 30, 60 days in residential, get them stabilized, and then, you know, in a perfect world, I'd love to see people do another 6 months in outpatient treatment. You know, it might start with day treatment and then evening IOP and then, you know, 5 days to 3 days, but that gives them the opportunity and the support to get back into their life and begin living real life and having those experiences with the safety of, you know, treatment, where they can process those things and triggers come up, and as different struggles come up for them, we can help them walk through that and remain sober. One of the things for us is, you know, early on, I remember thinking, you know, everybody I know in recovery that's really happy is super passionate about something. They get excited about something in their life. And, you know, for us here at Wasatch Crest, you know, that's why that rec therapy component is such a big part of what we do. Is it's you know, drugs and alcohol, regardless if it's opioids or you know, anything else, really does kind of rob us of passion and the things that we love in our lives. You know, slowly that stuff gets further and further away from your daily living, and helping clients really reconnect with what it is that they love and get re-engaged in that is super important. We just find that if we can get clients excited about something, we have one right now, for example, that we have an art therapy group, and he started painting a couple weeks ago. And I think almost every day I've come in, he's shown me some new art project that he's done, and he's really latched onto it, and it's made a significant difference. If it's hiking or running or skiing or snowshoeing or camping, you know, if we can help them find something along those lines to really get excited about, we can see some real improvement in the way that they live their lives. And
well, this is really sort of an interesting time in the pandemic, and this makes it particularly challenging to find those things because, right, the talents and the gifts and the things that people love doing have sometimes have to go underground a little bit right now and had to be put on hold. So being a little bit more, being a little better of a detective to look into what might bring them some fulfillment. What I often say with my clients is that, you know, happiness is fleeting, of course. Something could happen tomorrow. If I'm looking for always finding happiness, I might miss that. I'm gonna be unhappy because the goal is not always attainable, but finding some sort of purpose or meaning, which I think comes from some of the talents and goals and aspirations that people have. So it's trying to look at, yeah, what is it? What is it that's filling that bucket that's been emptied out from the pandemic or from your addiction, the loss of family, the balance has become unbalanced in your life. And so let's, you know, start focusing on that because it really is. Residential treatment's a short time, relatively speaking. So being able to work on the traumatic experiences that we can't do fully in residential, looking to get them to start looking at future, being more future oriented and finding what they love to do. There's lots. There's music, there's mountains, there's art.
Absolutely. Yeah. Flip to the next slide, Caleb, please. Okay, so we've touched on this a little bit, right? You know, the recovery piece is really where, you know, the magic happens. I think watching people rebuild their lives and live a life in recovery is a beautiful thing. And I think specific to recovery is the ability to connect with other people and find that, you know, sober support. I love, you know, at least in our community, years ago, it was mostly all different 12-step programs, which were fantastic. But over the past several years, I've seen things like YPR. It's Young People in Recovery. There's a thriving YPR community in Salt Lake and even Heber and Park City. And things like Addict to Athlete and Fit to Recover. Yeah. There's a great program in just north of us that does meetings. It's, now the name's escaping me, dang it. But it's similar to Fit to Recover. They you know, offer meetings, group workouts and classes, and it's the SOAR program, what it is. And all of these different community resources are so incredibly crucial. And then continuing somebody's therapy and trauma treatment, following their residential and intensive outpatient. Oftentimes they tell clients when they come to us, we'll begin to work on some of the trauma, but really if we can identify that and get a good game plan laid out for them that they can start working on that, it takes time. And it's not something you can tackle in 30 days. And it can take years, right? Mm-hmm. And so, we spend a lot of time with a lot of our clients really identifying trauma and helping them understand that their experiences maybe that they thought were normal, they maybe need to take a step back and take a look at that stuff and start working on it. But seeing our clients in recovery, it's absolutely my favorite part of the job. If somebody reaches out, check in and shares the beautiful life that they've built, it's an honor to watch them get there. So do we have any questions?
We don't have any questions right now, but feel free to type your questions into the control panel. Just to preview our next webinar, we are going to be talking about recreational therapy on February 12th at 10:30 a.m. Mountain Time. Our director of recreational therapy, Adeline Cook, is going to be giving the presentation. So feel free to sign up for that if you're interested. There is our admissions phone number, it's 24/7, and then our website, wasatchcresttreatment.com. And no one has any questions. So thank you guys so much. Thank you, Rich and Kevin.
Yep, have a good day, everyone.
Have a great day.